Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
The first case in this series is not severe. However, there are a few things to note. The short upper lip, the long lower lip, the interposition of the tongue during speech as the tongue compensates for the discrepancy between the two jaws. There is not a normal lingual dental possibility in articulation with this degree of open bite anteriorly. We can see the limited functional occlusion here with contact only on the second molars. The second molar occlusion, however, is fairly good, and through a study of the records on this case, the casts shown here suggest that the displacement of the anterior segment posteriorly and superiorly with the removal of the mandibular first molar will bring this jaw relationship into a significantly improved functional contact. There will be, along with this, an improvement in the facial profile, in the musculature around the mouth, and in the tongue relationship. So this would be the manner in which the segment of bone will be removed in this operation, which we have termed an ostectomy because there will be removal of bone. In contrast to the term osteotomy that we'll see later, in which just infers that the bone is cut, but no quantity of bone is removed. The free gingival margin flap reflected here gives access to the buccal region, and a flap is also reflected from the alveolar crest on the lingual. The anterior extension of obliqueness releases the flap so that we can get access to a lower level. The removal of the tooth then proceeds in a fairly routine extraction. You will notice that the title suggested that this operation necessitates a tooth in the posterior segment in order to control that segment. This operation can lead to difficulties if there is not sufficient dental control of the posterior segment of the mandible. With the flap then reflected, the periosteum is retracted downward. The bone drills are cutting through the cortical plate and into the socket area. This template was made from those casts that were just shown. It is a metal guide that takes into account the dimension of the drill cut. And with such a template, it is possible to be quite accurate within fractions of a millimeter in the quantity of bone that is removed. Not only is the width of the bone cut important, but there can be a good deal of compensation for the rotations of the anterior segment, depending upon how much bone is removed at the alveolar crest as compared with that at the inferior border. In other words, the open bite can be closed by tipping that anterior segment back. These drill cuts then through bone are carried through the lingual plate, being careful to protect the periosteum as we go through. They are made parallel, and this removal is under rather low speed conditions. Currently that is simplified. The cut then is made down to the level of the inferior alveolar nerve. The buccal cortex can be marked to a slightly lower level, but the flaps then are closed in this two-stage operation. This is only one of the several manners in which this osteectomy can be performed. It is a rather useful and conservative way to perform the operation. It has been performed in one stage and entirely intraorally, or it has been done entirely extraorally. But this is by far the more conservative, rather keeping the intraoral approach isolated in time from the extraoral. One note in passing that might be a logical question: why is the bone left in this alveolar crest region in the healing interval from the time these molars are removed and the bone cuts are made until the second stage of the operation? The purpose of leaving the bone there is to support the mucoperiosteal flaps so that they do not fall down into the bone defect and become a barrier to the later retrusion of the mandible when the bone cuts are completed. Here are the radiographs then showing what was accomplished. We now see, in this instance, orthodontic appliances that utilize banding of individual teeth and a heavy arch. The healing is complete intraorally, and we'll now proceed with the second phase of the operation. Although this demonstration case is done under local anesthesia, it is indeed rare to perform this operation under local. It's possible, and when making movies and this going is slow, it's a little safer, perhaps, but by and large, most of the cases of osteotomy and osteectomy are done under general anesthesia with nasal endotracheal intubation. The dissection is being carried out here in layers through the skin, superficial fascia, platysma muscle, and now down through periosteum as the periosteum is reflected to the target, and the target, of course, are those two cuts that were a part of the first stage procedure. Here they are identified, and using the guides again, the cuts will be completed to the inferior border. In this procedure, a great deal of care is taken to preserve the inferior alveolar neurovascular bundle. And you will see in a moment, as the cortical block is removed from between these two cuts, you'll see the little bony canal that surrounds the nerve and blood vessels, and effort is made to preserve that tract. And because there is some slack or excess in those structures when this segment is moved backward, an effort is made to accommodate for that extra material by countersinking and removing some of the bone from the immediate vicinity of the canal and the adjacent fragments, so that it will not be compressed and pinched off as the retrusion is made in the operation. The cortical bone at the inferior border of the mandible is exceedingly dense, and we'll be cutting through that. by taking these areas of bone off in segments, the fragments are kept under control. The lingual cortex is still intact, and therefore, as we lift off the buccal or lateral cortex, the fragments remain in their correct position, and you'll see later why that is important. Here, with the help of some suction, you're beginning to see the canal. Here it is. Notice the little thin layer of bone, cortical bone. That's the white line that is seen in radiographs of that structure, and it's being peeled off here in order to liberate the nerve and vessels, and we will then continue bone relief, expanding the canal diameter in the vicinity where there will be excess nerve. And one thing that you will eventually note here is that when the lingual cortex that is bridging those fragments, when that is removed, this space tends to collapse very rapidly, and the fragments are difficult to manage. So this rather meticulous work of guarding and protecting the nerve and doing this little bit of expansion through the relief of adjacent bone is better done before things are moving around. Similarly, these holes for transosseous wire fixation are better placed here and now while the fragments are stabilized than when they're moving around. You'll recall in the study of those casts that the fragment moves up and back. Therefore, these holes drilled with a surgical spear point drill with saline irrigation, as you have seen there, are not on the same horizontal plane, but they accommodate what will be the new horizontal plane between the two holes as the anterior fragment will be moving upward and backward. Now, from the periosteal envelope that has healed from 1 month previously, that alveolar block of bone is removed. And now as finally the lingual bridge of bone is delivered, you can see immediately the reduction in the space between the fragments, and they move independently. They are only temporarily slightly brought together. Notice the wire is not firmly secured. The reason that it is not firmly secured, of course, is that the true target position of that anterior segment has not been reached, and it will be determined not by the bone contact margins that are fairly arbitrary, but truly by the functional occlusion. So again, repeating the same approach on this side, which we'll try to abbreviate a little. The bone block will be eliminated and nerve preserved and temporary holes placed before proceeding intraorally with the adjustment of the entire anterior fragment, relating it to the functional occlusion that is the goal of the operation. As we indicated earlier, there are less arduous ways of removing bone these days. Rotary instrumentation with high speeds and newer devices has greatly simplified this operation that is being performed here carefully, but rather laboriously. The same anatomic consistency of the tube-like canal is demonstrated. Slightly less bone is removed from this side, as calibrated out in the model study. And we'll soon be in a position where the segment can be fitted into its goal position. Wire is temporary again and not finally secured, but we do know that this segment's going up as well as back. Note the great mobility of the anterior segment. Once it's been divided, you can put this anywhere you want to. In this instance, it goes to a predetermined occlusal position that is a fine target, and there is the immediate satisfaction of knowing that the arbitrary fracture and bone removal has achieved a correction. Care in this two-stage procedure is taken to avoid intraoral and extraoral cross-contamination, and so before returning to these open reduction sites, the gloves are changed. The transosseous wire fixation is identical to the open reductions of fractures. The requirements of repair are quite similar. A little more extensive here in this drill cut than with a traumatic fracture, in which there is less disturbance to the bone margins in most instances. The closure here is fairly routine. The insertion of drains has been something else that now is no longer customary or required. Purposes of drains are pretty much limited to evacuation of infections and evacuations of hematomas. With reasonable care, the quantity of bleeding in these sites is quite limited, and with pressure dressings, things heal without the need for drains. In this rather long procedure, the edema in soft tissues is rather extensive. You'll see that that will be gone in a follow-up. The radiographs indicate that the position is satisfactory of bone fragments. These patients do amazingly well. A return here to review what the pre-op conditions were like insofar as facial bone contour is concerned, and the malocclusion. This follows then the removal of the appliances, and the patients get along very well during the fixation period. Although restricted in diet, they're able to talk and function reasonably well. The early return of jaw function in the mandibular ostectomy is very rapid. The basic neuromuscular patterns are not appreciably changed in the ramus. We'll go through a series here of pre- and post-operative views to suggest some of the range of variables in the intermaxillary disharmonies that can be corrected by this procedure. Many of these situations are not ideal, and many of them reflect a disharmony that is more than a problem in the mandible. Many of them have associated maxillary deficiency as well as prominent mandibles. However, in this series, the attention is made primarily to the surgical correction through the mandible. The refinements in the occlusion can be achieved through pre-surgical and post-surgical orthodontics, and also in selective grinding with some equilibration that may bring the dental occlusion into satisfactory contact. So considering that's all that this case had, he has good functional occlusion. Occasionally he will wind up, as you see, in the right molar region with a crossbite, where the maxillary arch is more narrow than the mandibular. Nevertheless, a vastly improved functional occlusion. This patient has an artificial flipper for the replacement of his incisors in the maxilla. The unopposed mandibular teeth tend to extrude, so often the occlusal plane is distorted considerably by the migration of these teeth. Here we see then a splint bite block incorporated for the fixation. Often, if there is a good deal of residual irregularity in the occlusion and some gaps and deficiencies, splints can be utilized to control the jaw during that fixation time. We have not indicated the psychological benefits of this procedure and have more or less emphasized the malocclusion and dental significance of the corrections, but it's obvious that many of these patients are vastly improved in their outlook, personalities, many of them in their socioeconomic potentials by eliminating the disharmony in their facial structure that attracts attention and can bring about degrees of personality warping and inhibitions and limitations. That correction was rather extensive. We have the last case in this ostectomy series shows again the tongue interposed in speech. These patients have moist speech. The floor of the mouth is held forward and the submaxillary ducts often squirt out rather directly when the lower jaw is in this forward position. The articulation and speech do improve post-operatively, another of the side benefits. One certainly can see here that the teeth in these arches have not had any function. It would have been certainly far better to have some pre-surgical orthodontics to align these, but even accepting their irregularities, he has an improved facial profile, which suits him most. The reason he's grimacing here is to demonstrate that his facial nerve is intact and his mandible is moving pretty well. The hairstyle is not a feature of the operation, but it is interesting to see how the individual's attitude toward his personal appearance again changes when he at least has a conformity to his profile. We don't have any testimonials for Hollywood contracts, but in general, the improvements are gratifying to those responsible for the planning and correction. This concludes that series of ostectomies. We now look at a patient who also has a mandibular prognathism, but in this instance the correction will be carried out in the ramus of the mandible instead of the body region. The procedure will be a vertical ramus osteotomy. A number of the features associated with mandibular prognathism and open bite you likewise see in this case. Arch bars, in this instance orthodontic appliances again have been used. The movement is going to be a unit movement of the entire mandible in this situation. The study casts suggest that with some equilibration, the mandible can be retruded as a unit to be accepted in the functional relationship with the maxilla. It is quite surprising how there may be reasonable arch symmetry that is preserved even though the two jaws have not been working together. The patient is now in the operating room with nasal endotracheal intubation. The level of the incisions is being marked beneath the angles of the mandible before the head is turned. This enables you to mark the level of the incision so that they are symmetrically positioned and they are below the angle in an inconspicuous area where they often blend in to the creases in the neck in that situation. Incision through skin, superficial fascia, and now through the platysma. The division of the platysma. Placement of the vein hook retractors. That vessel will be individually clamped and ligated. It directly crosses the path. It's not a major vessel. It's not the facial artery or vein. It's just a small tributary of that system. The approach here is made beneath the platysma, and the mandibular branch of the facial nerve is superior. It is often identified in the dissection, and it is lifted up. Occasionally the tail of the parotid gland is similarly encountered here, and occasionally also in the posterior area of the incision the great auricular nerve may be encountered. We're now approaching the angle, and the dense tendinous insertion of the masseter muscle is being dissected. The masseter will be reflected entirely from the lateral border of the ascending ramus. Here there's a stripping action as we strip the fibrous insertions of both the masseter and medial pterygoid away from the angle region and from the ramus. We now have a retractor that is lifting up the masseter muscle, parotid gland, facial nerve, and by using a long crosscut drill irrigated here with saline, a cut is being made from the sigmoid notch down behind the inferior alveolar canal, and this will divide the posterior border of the ramus and the condyle from the rest of the mandible. So that now is a mobile segment. The only muscle that is left attached to this posterior segment is the external or lateral pterygoid. The fragment will be held laterally, the operation carried out on the opposite side the same way before going into the mouth, and again adjusting the position of the mandible. That is done while the wounds are kept open, and the fragments are now overriding. The posterior fragment is lapped laterally, and it remains so and is held there during healing and remodeling. The functional occlusion is established. The wound is then returned to after a change of gown and gloves and a return to the aseptic technique of the operating room. Here we see the lapped fragments, and those are generally secured by means of a single transosseous wire. The area is then enclosed with the return of the masseter and medial pterygoid sling joined again underneath the now modified angle and retruded mandible. The wound is closed in layers, and the platysma here is the next of the levels to close. These are absorbable buried sutures that you recognize, and the skin will be closed in another moment with standard methods. By carrying out the dissection in layers and identifying those layers, the closure can be greatly simplified, and we get tissues back to their original position with a minimum amount of distortion and with the resultant minimum amount of trauma and less scar tissue. This is a vertical mattress suture designed to give some slight eversion to the skin margin, anticipating the characteristic depression of scars, and by doing this, the final result will be a flat scar when healing is complete. So we now have the wound closed, and the pressure dressing will be applied. The fixation period for mandibular vertical ramus osteotomy amounts to, again, 6 weeks on an average, but that is followed by a period when training elastics for early motion are very important. It is obvious that the disturbance in the masticatory system, the disturbance in the musculature, their origins and insertions, is far greater in this operation than it is in the body ostectomies that were shown earlier. Nevertheless, good function results from this procedure, and there are many instances where the unit retrusion of the entire mandibular arch is an advantageous method of correcting mandibular prognathism. A little longer term follow-up here. This is at about 2 months after the procedure. There will be, in the first 6 to 8 months, a tendency for a prominence of the mandibular angle where there is the excess overlap. That remodels rapidly, and after 1 year, there is a complete return to a single thickness in the mandible as the callus remodels, and the temporomandibular joint is not disturbed as one might anticipate it should be really by this procedure. It adapts extremely well, and in the remodeling process, its relationship with the glenoid fossa of the temporal bone is entirely satisfactory. Some of these excursion movements in this early phase are a little hesitating, you've observed, And it takes a while for the neuromuscular system to develop its new reflexes. And so there's that's one of the reasons for having a good occlusal target and good proprioception. Another case for vertical ramus osteotomy. This is a rather typical girl, 20 years of age, who has a prominent mandible, very self-conscious. She is an efficient secretary, but her social life has not been what she would like it to be. This girl is partially edentulous, as you will see in the cast in a moment, and it's surprising, in spite of all this distortion of tooth loss, how reasonable symmetry of the arches was preserved. Here are the related casts, and you can see the severe discrepancy and the overclosure that exists as the mandible literally telescopes the constricted maxilla. But here, with a retrusion of the entire mandible, we pick up amazingly good function, even molar contact, and it was for this reason that it was elected to shift the entire mandible backward. You will note the same improvement in soft tissues. As the chin is less prominent, there is not the overclosure function. The scars you see are inconspicuous even early. This is at some 4 months post-operatively. And her social life improved, as well as her function in mastication. These then have been a series of corrections of mandibular prognathism by two methods, one for the body region and one for the ramus region, both yielding satisfactory results.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.